Hey guys, welcome to my YouTube channel. I am Dr. Kofi, and today's edition will feature a clinical case discussion in pediatrics based on the Ghana Medical and Dental Council exam. And if you've been following our discussions, you will realize that this is our third case discussion in pediatrics. Kindly like and share this video and subscribe to our channel if you find this helpful, and kindly hit the notification bell to get notified anytime we release new videos. Alright friends, let's begin. Alright, and so today's clinical case is a past GMDC exam question, and it reads: a 5-year-old child with a history of fever, cough, and runny nose later started complaining of earache. He was brought to your facility and was examined, and a diagnosis of acute otitis media was made. Now, there were 4 questions for this clinical case. The first was: mention 3 findings on autoscopy. Now, autoscopy is the use of a portable hand instrument called the otoscope to visually examine the eardrum or the tympanic membrane and then the external ear canal, like this lady clinician is doing in this picture. Remember that here, we don't just give answers to the questions asked, but we try to understand the clinical condition. And so before we answer this first question, let's get some relevant basic sciences to help us appreciate our patient's clinical condition. Very good. And so this diagram shows the anatomy of the ear. Let's get some orientation by labeling some relevant parts. The first is the pinna or the auricle, which we see externally. And then the ear canal or the external auditory meatus. The pinna and the ear canal forms the external ear. What the pinna does is that it receives sound waves and directs them into the middle ear through the ear canal. Then we have this membrane, crudely called the eardrum, but medically known as the tympanic membrane, which separates the middle ear from the external ear. Clinically, it is considered part of the middle ear since its changes can tell us about pathological processes in the middle ear. And so the sound waves from the external ear vibrates this tympanic membrane, which amplifies the sound waves. Then next, we have the 3 ear ossicles seated in the middle ear cavity, as you can see, or the tympanic cavity. They are the malleus, the incus, and the stapes. So the amplified sounds are transmitted through these bones and finally into the inner ear. Then the next structure we will label is the cochlea, which is the region basically responsible for hearing because it has the organ of hearing called the organ of Corti. Then from the cochlea, the information is transmitted through this structure, the cochlear nerve, and the cochlear nerve sends the information to the brain to be interpreted. Next, we have this tube known as the eustachian tube, which connects the middle ear cavity to the nasopharynx, as you can see. Its function is to keep the pressure in the middle ear cavity constant and equal with the atmospheric pressure. Remember, the pressure in the external ear canal, which is part of the external ear, is the same as the atmospheric pressure. And so can you imagine what would happen to the tympanic membrane or the eardrum if the pressure in the tympanic cavity were not kept the same as the atmospheric pressure? Then what would have happened is that the eardrum or the tympanic membrane will be forced to bulge in because the pressure in the ear canal is more than the pressure in the middle ear cavity, and that will affect its ability to amplify sounds and so might lead to some level of hearing impairment. Now, because of the connection between the nasopharynx and then the middle ear, upper respiratory tract infections, which also affects the nasopharynx, can spread from the nasopharynx into the middle ear, causing otitis media, like it happened to the patient in this case. And kids or children are particularly susceptible from getting acute otitis media because their eustachian tube is short, and so it takes a very little time for the organism to spread from the nasopharynx into the middle cavity, and also because it's broad, and so it paves so much way, and lastly because it is horizontal, and so gravity cannot pull them once they start entering the tube into the middle ear cavity. Good. And so when a patient or a child presents with a history that is suggestive of acute otitis media, such as earache, which is particularly pulsating or throbbing, fever, headaches, ear tagging, and some level of impaired hearing, we do otoscopy, and as said earlier, the otoscope with its light helps us view the ear canal and the tympanic membrane, again as shown in this diagram. Good. And so now let us compare how the tympanic membrane looks like in the normal state and when there is acute otitis media on otoscopy. This is the normal eardrum on otoscopy. And this is what we call the cone of light, or the light reflex, that triangular light we see there. Then remember that right behind the eardrum is the malleus, which is one of the ear ossicles, and it's the first ear ossicle right behind the eardrum. And so here is the handle of the malleus, and at its tip is the umbo. Now the membrane itself, the tympanic membrane, has a flaccid part known as the pars flaccida here, and then the tense part known as the pars tensa. Now see overall that the membrane is pink like any healthy tissue in the body, and it is not bulging, and you can see that the parts of the tympanic membrane are distinct, like the handle of malleus, the light reflex are distinct. Now how is the situation in acute otitis media? This is a picture I got from Medscape, and this answers our question A. Mention 3 findings on otoscopy, and because it is an inflammatory process, we would expect to see some of the inflammatory processes on otoscopy. So one of them is that the tympanic membrane will be bulging. It will be bulging because of 1, it is edematous, and 2, because of the inflammatory process going on in the middle ear cavity. It increases the pressure in the middle ear cavity compared to the atmospheric pressure, and so that pressure would bulge or would push the middle ear cavity, the tympanic membrane out. Then as well, there's an inflammation, and so the middle ear cavity, the tympanic membrane will be reddened, and so you have erythematous tympanic membrane with indistinct landmarks. We can't really see the handle of malleus, we can't see the umbo, we can't see the cone of light, etc. Then there will be opacity, so it will be opaque again because of the inflammatory process. Light cannot really go through the tympanic membrane. Then there will be loss or displacement of the cone of light, like we said earlier. Then as well, there will be an exudate, or there may be an exudate in the ear canal, particularly when the organism is pyogenic. And so these are some of the findings that can be found on otoscopy or during otoscopy, and that answers our first question. Very good. And so the second question which was asked for this clinical case was, list 6 investigations you will carry out. Now I must say that in acute otitis media, one of the investigations you do is actually the full blood count looking for neutrophilia. And then you don't do ear swab for culture and sensitivity, because the teaching is that you treat the otitis media with sensitive antibiotics like augmentin for 10 days, and if there is no improvement, then you can take ear swab for culture and insensitivity. So the second investigation to do is an ear swab for culture and sensitivity, and this is all there is to do for acute otitis media, really. But because the question has pushed us to give 6 investigations, then we need to do more. For example, this patient may present with fever, and so we need to do a blood film for malaria parasites to rule out the fact that malaria is not responsible for his febrile episode and other symptoms that is common to both otitis media and malaria. Then we may do a sputum we may take a sputum for culture and sensitivity. We may do an ESR, which would tell us that there is an inflammation. We may do a plain chest radiograph, which may also pick up pneumonia if there is pneumonia. Of course, there's an upper respiratory tract infection that was associated with pneumonia. Then we had acute otitis media. But typically, the investigations we do in otitis media, we do a full blood count, and we do not routinely do ear swab for culture and sensitivity unless the empirical antibiotics is not giving any signs of improvement after at least 10 days, at most 10 days of treatment. Then the third question read, mention 4 complications of acute otitis media. So one of the complications is that there may be facial nerve involvement, which would give you a facial nerve palsy, because the facial nerve also courses through the middle ear, and so if there is an infection in the middle ear, it may involve the facial nerve and would give you a facial nerve palsy, which will manifest as facial deviation, etc. Now, the infection can also spread posteriorly into the mastoid process and give you acute mastoiditis. It can spread medially to involve the brain, and that can give you a cerebral abscess. That is the temporal lobe that can give you a cerebral abscess. It may even spread into the cerebellum that can give you a cerebellar abscess and give you cerebellar signs. It can also spread into the subdura and give you subdural empyema. It can go above the dura mater and give you an epidural abscess. It can cause meningitis. The infection can cause sepsis and then septic shock, etc. Then the last question of that clinical vignette for that particular year read, mention the drugs you will use in managing the condition. Of course, you have to treat the underlying cause, so we give broad spectrum antibiotics like amoxicillin. One of the brands is called augmentin. Then you have to manage the symptoms, and so for the earache, we give analgesics like ibuprofen, paracetamol, etc. Then he or she may, or the patient may have nasal congestion, and so you have to give nasopharyngeal decongestants like ephedrine. And so your antibiotics, your analgesics, and then the nasopharyngeal congestants or decongestants, I wanted to say. And so this is the end of today's pediatrics tutorials. Thank you guys for watching once again. Kindly, as usual, do not forget to like our videos and then hit the share button. Share it to anyone you think might need this video, and kindly do not forget to subscribe and hit your notification bell. I will see you in our next video. Until then, adios. Bye.